Hello everyone, today we'll be talking about ECG basics. We're going to discuss on how to approach an ECG reading in a systematic way. So the outline of this video is we're going to look at the paper speed, rate, rhythm, axis and intervals of an ECG reading, step-by-step approach to reading an ECG. Then we're going to look at ECG rule of force. So this helps us reading an ECG in a systematic way and ensuring that we don't miss anything. Then we'll briefly discuss lead placement, okay? So understanding paper speeds. Paper output speed, this is basically the rate at which the ECG machine produces a trace. Okay, so the standard output is 25 millimeters per second. So this is the speed we're talking about, 25 millimeters per second, okay? So one small square is 1 millimeters, and that is equivalent to 0.04 seconds or 40 milliseconds. 5 small squares, which is 5 millimeters, is equivalent to 1 large square, which is 0.2 seconds or 200 milliseconds. And 5 large squares make 1 second, okay? So let's look at this. This is one small box, right, which is 1 millimeter. This is 0.04 second or 40 milliseconds. Then 5 small boxes, or we can call this one large box. This is 0.2 seconds or 200 milliseconds, okay? Then we talked about 5 large squares, is 1 second. So starting from here, 1, 2, 3, 4, 5. So 5 large boxes make 1 second, okay? So at standard paper speed of 25 millimeters per second, the rhythm strip comprises of 250 small squares, which is equal to 50 large squares and which is equal to 10 seconds. So one strip basically covers how many seconds? 10 seconds, okay? Before calculating rate in beats per minute, we should understand that a rhythm strip recorded for 1 minute will therefore comprise 1500 small squares, 300 large squares, which are equivalent to 1 minute. So how do we calculate the rate of an ECG? So there are 3 main methods of calculating the rate of an ECG, and certain methods are better suited for rhythms such as bradyarrhythmia, which is a slower heart rate, or tachyarrhythmia, which is a faster heart rate than normal. So the first method we'll talk about is the large square method. So if you remember what we just talked about, we said that 300 large squares is equal to 1 minute at a paper speed of 25 millimeters per second, right? And this is the most common paper speed that we have. So we can thus calculate the beats per minute by dividing 300 by the number of large squares between each R to R interval, okay? So the space between 2 consecutive R waves is 1 beat. So let's look at this. So we said we divide 300 by the number of large squares, okay, between an R to R bit. So this is the R bit that we're talking about, okay? So if there's just one large square, so we do 300 divided by 1, so that would give us 300 bits per minute. Now in this case, if there are 3 boxes here, 1, 2, 3 large boxes, we do 300 divided by 3, which gives us 100 bits per minute, okay? If there are 5 large boxes, 1, 2, 3, 4, 5, 300 divided by 5 will give us 60 bits per minute. So this large square method, it's very useful for regular rhythms, okay? And it's actually the quickest method that we commonly use, that is for a regular rhythm, okay? Then this is another method, which is the small square method. This was the large square method, this is the small square method. So you divide 1500 by the number of small squares between R to R interval, okay? So here we do 1500 divided by 5, which is 300 bits per minute. The same as this, remember? So here we just divided it by 1 large square. Here we divide them by the small square. So we count here 1, 2, 3, 4, 5. So 1500 divided by 5, that gives us 300 bits per minute. The same, if there are 15 small squares, we divide 1500 divided by 15. So that gives us 100 bits per minute. We can just count 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So 1500 divided by 15, then we get 100 bits per minute, okay? So this is useful for very fast regular rhythms, and it's likely to provide more accurate rate than large square methods. So if you use this method, it's better for fast regular rhythms and it's more accurate than the large square method. The another method is the R wave method, where rate is the number of R waves in a rhythm strip by 6. So the number of complexes, you count the R waves on the rhythm strip, and it gives the average rate over a 10-second period. So this is multiplied by 6. So 10 seconds times 6 will give you 1 minute, okay? So it's useful for slow and irregular rhythms. So what we do is, so remember we said that one strip is about 10 seconds, right? So we count the number of R waves in a 10-second strip. So we count 1, 2, 3, 4, 5, 6, 7, 8, 9. Then we do 9 times 6, okay? So we say that we count the number of R waves which we just counted. It was 9, right? Then we multiply that by 6. So what is 9 times 6? That's 54 beats per minute, okay? So when we look at this strip or this diagram, it's showing us all methods. So this is the small square method, this is the large square method, and this is the R wave method. So in the small squares, we just counted the number of small squares in between an R to R interval, and then we did 1500 divided by the small squares. We got 55.6, which is rounding off to 56. Then on the large square method, we counted the big boxes. So 1, 2, 3, 4, 5, and then there's a little bit of here. So that's about 5.4 large squares. So did 300 divided by 5.4, that gives us 55.6, which is roughly 56 beats per minute. Then this is the one that we just counted. So they were 9 R waves, and then we multiplied that by 6. So we get 54 beats per minute, okay? So you can decide to choose whichever method you're more comfortable with. I commonly use the large square method. So comparison of three methods. So the R wave method is often easiest as a quick calculation. So interpretation. So if you get between 60 to 100 beats per minute, that is normal. Above 100 beats per minute, that is tachycardia, and below 60 beats per minute, that is bradycardia. And this is just the reference range for children, okay? So remember we talked about the most common paper speed was 25 millimeters per second. However, we also have 50 millimeters per second. So in 50 millimeters per second, you are doubling the standard rate, okay? So the ECG will appear to be drawn out, or there will be wider complexes, okay? So 1 millimeters will represent 0.02 seconds. 5 millimeters will represent 0.1 seconds, okay? So when we look at the rhythm strip, it will comprise 5 seconds total, okay? Remember our 25 millimeter strip comprised of 10 seconds. If it will be 50 millimeters, it will comprise of 5 seconds, okay? So why use a 50 millimeters per second strip? So when we double the standard rate, it can reveal subtle ECG findings that are hidden at the slower rates, okay? In particular, atrial flutter waves, okay? So at 50 millimeters per second, P waves are more discernible in a 2:1 ratio to QRS complexes. So when we're going to look at 25 millimeters, we are not able to appreciate so much here, okay? However, when we use a speed of 50 millimeters per second, the P waves are better discernible, okay? Then the next speed is 10 millimeters per second. In this one, 1 millimeter represents 0.1 second, and 5 millimeters represents 0.5 seconds. So let's go through the step-by-step approach to ECG rhythm analysis. So we start with the rate, which we already talked about. Is it tachycardic or bradycardic? So the normal heart rate is 60 to 100 beats per minute. Then secondly, we need to look at the pattern of QRS complexes. Is it regular or irregular? If irregular, is it regularly irregular or irregularly irregular? Okay. Then we look at the QRS morphology. So is it narrow complex or is it wide complex? So narrow complex is whereby you think of sinus, atrial, or junctional origin, and wide complex you think of ventricular origin or supraventricular with aberrant conduction. So once we look at our complexes, you know what I mean. Then P waves, are they absent? If P waves are absent, we're thinking of sinus arrest, atrial fibrillation. If P waves are present, we need to look at the morphology, the PR interval, okay? Then we need to look at the relationship between P waves and QRS complexes to look at atrioventricular dissociation, complete. Atrial and ventricular activity is always independent, okay? Onset and termination. If there's an abrupt onset, it can suggest re-entrant process, and if it's gradual, suggests increased automaticity. Response to vagal maneuvers. Sinus tachycardia, ectopic atrial tachydysrhythmia, gradual slowing during the vagal maneuver. We will now look at the ECG axis interpretation. So cardiac axis represents the sum of depolarization vectors generated by individual cardiac myocytes, okay? So clinically it is reflected by the ventricular axis, and interpretation relies on determining the relationship between the QRS axis and the limb leads of the ECG. So the normal cardiac axis is between -30 and 90 degrees, okay? So this is the normal cardiac axis. So since the left ventricle makes up most of the heart muscle under normal circumstances, normal cardiac axis is directed downwards and slightly to the left. Normal axis is between -30 and 90 degrees, and abnormal axis deviation indicates underlying pathology. So left axis deviation, QRS is less than -30, and right axis deviation, QRS is greater than 90 degrees. So if it's greater than 90, this side, then it's right axis deviation. If it's above -30, so that is left axis deviation, okay? From here to here and here to there. Then extreme axis deviation, that is when the QRS axis is between -90 and 180 degrees. So from here all the way to here, okay? So this is a bit better depiction. So it's our normal QRS axis, -30 to +90 degrees. Left axis deviation between -30 and -90. Right axis deviation between 120 and 180. Sorry. Yeah, between 120 and 180. And then extreme axis deviation is over here. So methods of ECG axis interpretation. There are a number of methods. I've mentioned 3 here. You can find which one suits you better, and then you can be using that. You don't need to use all the 3. So there's the quadrant method, in which you look at lead 1 and AVF. And then there's a 3-lead analysis, in which you look at lead 1, lead 2, and AVF, and isoelectric lead analysis. So method 1, the quadrant method. This is the most efficient way to estimate the axis, is to look at lead 1 and lead AVF. You need to examine the QRS complex in each lead and determine if it is positive, isoelectric, or negative. So if we look at this one, the R wave is greater than the S wave. So this is a positive wave. If R wave is equal to S wave, that is equiphasic. And if the S wave is greater than R wave, or we can say R wave is smaller than S wave, that is negative, okay? So a positive QRS in lead 1 puts the axis in roughly the same direction as lead 1. A positive QRS in lead AVF similarly aligns the axis with lead AVF. So combining both colored areas, the quadrant of overlap determines the axis. So if lead 1 and AVF are both positive, the axis is between 0 and 90 degrees. So try and remember at least this lead 1 and AVF. If they're both positive, the axis is between 0 and 90 degrees, which is the normal axis. But look at this, lead 1 is positive, lead AVF is positive. So this is our normal axis between 0 to 90 degrees. So we can also do lead 1 positive and lead AVF positive. So that is normal axis. If lead 1 is positive and lead AVF is negative, that is a possible left axis deviation. If lead 1 is negative and lead AVF is positive, possible right axis deviation. And if both lead 1 and lead AVF are negative, there is extreme axis deviation. Okay. So method 2, 3-lead analysis. So in the first method, we looked at lead 1 and AVF, right? In this one, we look at lead 1, lead 2, and AVF. So a positive QS in lead 1 puts the axis in roughly the same direction as lead 1. A pure positive QS in lead 2 similarly aligns the axis with lead 2. So if lead 1 and lead 2 are both positive, the axis is between -30 and 90 degrees, which is the normal axis. So let's look at this. Lead 1 is positive, lead 2 is positive. So this is the normal axis, okay? So combined evaluation of lead 1, lead 2, and AVF, it allows rapid and accurate QRS assessment. The addition of lead 2, it can help determine pathological left axis deviation from normal axis or physiologic left axis deviation. So lead 1 is positive, lead 2 is positive, and lead AVF is positive. So this is normal axis, okay? So let's look at this. Lead 1 positive, lead 2 positive, and lead AVF positive, that's normal axis. If lead 1 is positive, lead 2 is equiphasic, and lead 3 is negative, or lead AVF is negative. That is physiologic left axis deviation, okay? Then if lead 1 is positive, lead 2 is negative, and AVF is negative, that is left axis deviation. If lead 1 is negative, lead 2 is positive, and lead AVF is positive, that is right axis deviation. If lead 1, lead 2, and lead AVF are negative, that is extreme axis deviation. And if lead 1, lead 2, and AVF are equiphasic, then that is indeterminate, okay? Then method 3, the isoelectric lead. This method allows a more precise estimation of QRS axis using the axis diagram below. So when we look at this, this is just the diagram we looked at earlier, okay? So the key principle is if the QRS is positive in any given lead, the axis points in roughly the same direction as this lead. If the QRS is negative in any given lead, the axis points in roughly the opposite direction to this lead. If the QRS is isoelectric in any given lead, this positive deflection equals negative deflection, the axis is at 90 degrees to this lead. So step 1, what you need to do is you need to find the isoelectric lead. The isoelectric or the equiphasic lead is the frontal lead with 0 net amplitude. This can be either a biphasic QRS where R wave height is equal to Q or S wave depth, or flatline QRS with no discernible features. Then in step 2, find the positive leads. Look for the leads with the tallest R waves. Then step 3, calculate the QRS axis. The QRS axis is at 90 degrees to the isoelectric lead, pointing in the direction of the positive lead. So these were the 3 methods of finding axis deviation, of determining the cardiac axis. So the ECG rule of 4, so you need to look at 4 initial features, 4 waves, and 4 intervals. So the key is to read each ECG methodically, following the basic structure, looking at all the leads. So the 4 initial features that you need to look for on an ECG is history of the clinical picture. This is the most important thing to look for on any ECG. Simple things need to be recorded like the name of the patient, the age, time, symptoms of the patient, and other clinical features. And you also need to do a quick check for lead placement errors. Then you determine the rate The normal value is between 60 to 100 beats per minute. Lower than this is bradycardia and higher is tachycardia. Rhythm, is the rhythm sinus or is it another rhythm? If so, what? Then the axis. Then the four waves or complexes on an ECG. So we look at the P wave, the QRS complex, the T wave, and the U wave. So P wave, lead 2 is usually the best lead place to look at the P wave morphology. You need to observe the P wave morphology, such as in particular in P pulmonale or P mitral, the P wave morphology is distorted. QRS complexes, you need to look in all the leads for the presence of Q waves and observe the QRS complex and look for QRS progression through the chest leads, which is V1 to V6. Then T waves, you need to look in all the leads for T waves. Look for T wave inversion, T wave concordance or discordance with QRS, and the presence of T wave flattening. Then U waves. So normally we don't see U waves, so you need to keep an eye, are U waves present or not? So let's look at a diagram. This is our P wave, our QRS complex. This is the T wave, okay? And sometimes you may see a U wave. So PR interval, this is from the start of a P wave to the beginning of the R wave, okay? ST interval is from here, from the end of the starting of the S wave till the end of the T wave, okay? Then QT interval, this is from the start of the Q wave till the end of the T wave, okay? So you need to have this interval in mind and you always need to calculate them, okay, to see if they're normal or not. Then this is just showing us a small box is equivalent to 0.04 seconds and a big box is 0.2 seconds. So the four interval or the segments in an ECG. The PR interval, so the PR interval is normally between 0.12 to 0.2 seconds, which is roughly 3 to 5 small squares. A prolonged or changing, especially lengthening PR interval indicates heart block. Shortened PR intervals can be because of Wolff, Parkinson-White syndrome, or a junctional rhythm. Then QRS width or QRS interval. The QRS interval is normally less than 0.12 seconds, which is about 3 small squares. A widened QRS width indicates some sort of conduction defect with the left or right bundle branches. ST segment, and this is one of the most important things to look at. You need to look for sloping, especially downsloping or flattening of the ST segments. QT interval, the QT interval is the time from the start of the Q wave to the end of the T wave. So this is basically the things you need to keep in mind when trying to interpret an ECG, okay? Four initial features, so we can look at the demographics, presenting complaint, etc. Then the four waves and the four intervals. So in a 12-lead ECG, 10 electrodes are required to produce the 12-lead ECG. So there are 4 electrodes on all 4 limbs. So this right arm, left leg, left arm, right leg, okay? And 6 electrodes on the precordium. So you need to monitor the 12 leads, which is V1 to V6, lead 1, lead 2, lead 3, and augmented right limb, then foot, feet, and left limb, okay? This allows interpretation of specific areas of the heart. So inferior leads are lead 2, lead 3, and AVF. Lateral leads are lead 1, AVL, V5, and V6, and anterior leads are V1 to V4. So 12-lead precordial limb lead placement. So V1 is placed in the 4th intercostal space, right margin of the sternum. V2 is placed in the 4th intercostal space along the left margin of the sternum. V4 is placed in the 5th intercostal space mid-clavicular line. V3 is midway between V2 and V4, and V5 is in the 5th intercostal space anterior axillary line, the same level as V4. And V6 is at the 5th intercostal space mid-axillary line, same level as V4. So V1, V2, V3, V4, V5, V6. Then posterior leads. So normally we do not place posterior leads. However, when you're when you're suspecting some pathology, then we need to do posterior lead placement, okay? So this is whereby lead V7 to V9 are placed on the posterior chest wall in the following position. So V7 is placed in the left posterior axillary line in the same horizontal plane as V6. V8 is placed at the tip of the left scapula in the same horizontal plane as V6. And V9 is placed at the left paraspinal region in the same horizontal plane as V6. So this is basically showing us which limbs are lateral, inferior, septal, and anterior. This is the limb placed in the right arm, right leg, left leg, okay? So that's all about ECG limb placement. Thank you for watching.